Welcome everybody to the last Lunch and Learn of the year, April 14th with Dr. Eric Crighton. The talk will be focused on access in healthcare in Ontario, as you can see from the title page. I'm just going to give a really quick introduction to Eric's bio and then let him take it away. So Eric Crighton is full professor in the Department of Geography. He's a co-director of the Environment, Community and Health Lab, and is a senior scientist at the Institute of Clinical Evaluative Sciences. Professor Crighton holds a doctorate and master's in geography from McMaster University and an undergraduate degree in geography from Ottawa. Dr. Crighton's research focuses on the themes of environment and health, geographies of health and healthcare, child health, psychosocial health, and environmental risk perception. His research is multidisciplinary in nature and involves the use of a wide range of research methods and data sources. He is currently leading a 3-year CIHR-funded project examining strategies for integrating environmental health education into prenatal care, and is a co-investigator in other projects, including one of the topic of today's presentation, access to Parkinson's related healthcare. Dr. Crighton has published widely on themes including environmental and socioeconomic determinants of respiratory disease, environmental disasters, and health, and also environmental risk perceptions and protective behaviors. And with that, please welcome Dr. Eric Crighton.
Great, thank you so much, Andrew, and thanks everyone for inviting me to do this. This is a great honor. So yes, the topic of my talk today is access to healthcare, a case study of Parkinson's disease. The presentation is focused primarily on my research looking at this. But I'd first like to just take a few minutes to sort of set this research in context of health geography more generally. I think health geography is not something that's very well understood, and I always feel the need to explain it a little bit. So I think it's important to recognize that the study of access to care that I'm talking about today is a very quantitative spatial analysis, and this is all very much sort of just a very small part of what health geography is as a discipline. So I'm just going to set that context a bit. So health geography more generally examines interactions between people and the environment. So we often will look at the physical environment, social, economic factors, and so forth, and how these influence people's health. It's very interested in the role of space and place. Tends to take a very a holistic perspective on health, in that it's interested not just in sort of the biomedical sort of description of a diagnosed disease, but would also be interested in mental health, psychosocial health, well-being, and so forth. So it takes quite a broad perspective. Methodologically, it tends to be quite diverse. The work I'm presenting here is, as I said, quantitative and spatial in nature. But for example, qualitative research is a very common sort of area of sort of methodological approach in health geography. And it tends to be quite pragmatic in that it aims to support and inform decision-making and policy-making. And so, the work we're doing here will hopefully, that I'm presenting here today rather, will speak to that a little bit. So there's this notion that, ultimately where you live affects your health. So there's this interest in understanding the relationship between, access to basic resources and opportunities within communities, the relationships between human interactions and human relationships and health, exposures, whether physical or social, to various hazards. So, environmental health, so the exposure to chemicals, for example, is an area of research that I'm interested in. And also there's quite a bit of work being done around, the relationship between treatments and healthcare access and so forth. And these are all very spatial in nature, and they tend to vary considerably across scales. And so we, work, these interrelationships and these relationships between health and place can be at the global level, to the regional level across the country, to different cities or within cities, within neighborhoods, within families, and then at the individual level as well. So there's these scales are quite malleable and variable. So we see considerable amount of research are looking at global patterns of disease. This is just one example, looking at the geographical distribution of cervical cancer by country. You can see clear discrepancies or inequities that exist with the highest rates found in much of South and Central Africa, as compared to, say, a country like Canada, where rates of cervical cancer are very low. And if you're wondering why this might be the case, cervical cancer is pretty much caused by HPV, or human papillomavirus. And it tends to be, HPV is very much linked to a weak immune system, and AIDS would be a big part of that. And so that's why you'd see the high rates in Southern Africa. It's also linked to sexual history and vaccination rates. And so the push to vaccinate for HPV is associated with this. Then it, coming down to a much more local level, you see clear health inequities or disparities across an area as small as Ottawa. This is a map courtesy of the Ottawa Neighborhood Study, which is Mike Sawada's baby. So you can see here that COVID rates vary considerably by neighborhood, and ultimately, if you broke that down further and zoomed into any one of these neighborhoods, you would see similar disparities within that. And so the further you zoom in, these disparities continue. So from global down to the very local. So, while identifying these patterns is important, the obvious next question is, why do these patterns exist in the first place? Like, what's going on? What can explain these patterns? And, frameworks like this is a population health framework, are commonly used by social scientists and health geographers and so forth to inform their research and explain some of the geographic and population patterns that might exist. Explanations of determinants of health and geographical patterns of health tend to be quite complex, and they're based on many of the factors that are presented or conceptualized here in this framework. Some affect health very directly, and others much more indirectly. And these more indirect factors would be considered sort of upstream factors, if you will. And so we can see the individual, so age and sex, of course, play a big role, genetics and so forth. And then this is influenced, or these further influenced, or health within these populations are influenced by individual behaviors, so smoking, drinking, exercise, diet, and so forth, and further influenced by social and community networks, these broad range of factors ranging from housing, which is clearly important, healthcare services, unemployment, education, etc., and all of which are informed or influenced by socioeconomic conditions, policies at the national level, cultural, environmental conditions, etc., etc. So the further away from the individual you get, the more complex the relationships are, and interrelated they tend to be. And so, any of these factors, so, education, for example, is clearly influenced by a wide range of other factors at the, the policy and cultural levels to, unemployment rates and how that affects the economy, et cetera, et cetera. So they're all tend to be quite interrelated. So, one of these determinants here is healthcare services, and that's more or less where I'm focusing my research today. But I'm also interested in how, what factors are ultimately influencing how healthcare is used, and that would include some of these other factors. So in, sort of traditional medical geography, factors, I guess access to healthcare tends to be sort of looked at in fairly simplistic ways. So the distance decay effect, a concept that many of you are certainly familiar with as geographers. This is commonly used to sort of demonstrate, or sorry, I should say, assess the access of individuals to healthcare. And so we see on this graph, this is looking at the relationship between distance to a clinic and doctor consultation rates. And you can see very clearly from this graph that as you move further away in kilometers from from the source of care, you know, the likelihood or the rate of consultation goes down quite dramatically, right? Which makes complete sense, right? Distance means it's less convenient to access. So a lot of attention has been spent sort of studying distance like this. And so while distance is important, it's very simplistic. And so you could imagine, for example, that distance might mean two very different things if you're in a rural versus an urban area. So perhaps in an urban area, time might be a bit more relevant. So you might live 10 kilometers away from your doctor, but it takes an hour to get there because of traffic. Whereas in a rural area, 100 kilometers might take an hour, right? So it's a bit problematic in that regard. So increasingly, access to care is examined in a much less simplistic way. You know, and it sort of starts, I guess, with a conceptual framework like this that, you know, attempts to consider all of the broad factors that might determine access and conceptualize access in a more complex way other than simply, you know, getting to the doctor. So factors affecting access are clearly very multi-dimensional, with specific access barriers covering a range of spatial and aspatial dimensions. So this model here covers the full continuum of access. And so if you see on the left, you know, sort of identifying need as part of what access is, I guess, actual, you know, attempts to seek healthcare, actually reaching healthcare, and you know, the utilization, and then ultimately sort of the outcomes as well. And this is what you'd sort of consider the continuum of access to care. And then on the top row, you have all of the factors that might, you know, theoretically determine access from a very structural perspective. And so you have things like, you know, information screening activities. Further, you've got professional values, norms, gender, cultural factors as well. We've certainly been hearing you know, a lot about the role of culture and racism within the healthcare system, with Indigenous people being denied care for, you know, due to assumptions of you know, being drunk or whatever else the situation was in the Quebec situation just recently. Geographic location, of course, plays a role, hours of opening, the costs, and then various other technical aspects. And then from in the bottom row, we see things like, I guess, more individual or population factors that might determine care. So we see, you know, health literacy, personal values, again, culture, gender, transport, access to transportation, social support, income, and then empowerment and adherence to care and so forth, right? So these are, you know, a wide range of factors that determine this continuum of care. You know, studying them all in any one study is almost an impossibility. This is a theoretical or a conceptual framework, but it's a good way to sort of think about access to care. And it's a much better way to think about access to care than a very simple sort of reaching your destination, because, you know, reaching the destination does not guarantee you will actually receive care. By the way, if you have any questions as I speak, please feel free to ask them. I don't mind. We don't need to wait till the end. So with that, that provides a little bit of context, I hope. What I'd like to do now is speak to this case study that is sort of the title of this presentation, and I'd just like to acknowledge the fact that I'm not the sole researcher on this project. This is a study that was done with a former graduate student of mine who's now an analyst at the Institute of Clinical Evaluative Sciences, Alexandra Ueduraago. Mike Sawada, of course, you know, and the principal investigator is Tiago Mestre. He's a neurologist at the Ottawa Hospital. And this is quite a large international consortium that's looking at strategies for improving care in the context of Parkinson's disease. And I'll speak to that a little bit in a moment. So just for a bit of context, Parkinson's disease, it's a progressive, non-curable neurodegenerative disorder. It affects about 35,000 Ontarians over the age of 60. Its prevalence is expected to rise, as you probably are well aware. The Canadian population is aging, and one of the major risk factors associated with Parkinson's is age. You know, Ontario healthcare system, it's universal access, so it's publicly funded care, yet, you know, as you can all imagine, that this does not guarantee access. There are significant barriers to care that exist beyond just those financial costs. So, you know, it's important to point out that while there is research being done looking at access to care in Parkinson's disease, and PKM refers to Parkinsonism, so it's not diagnosed Parkinson disease, but rather symptoms associated with it. So it's quite close. There's been very little research done in Canada for the most part. There's a couple of studies in Canada, but and even internationally, there's a few sort of geographic studies that have been done in the States and elsewhere, but it's quite a limited body of research, to say the least. So there's two components to the bigger project. The one I'm talking about today is the geographical analysis of health services use. So we refer to this as realized access. So this is access that has actually happened. So they've arrived at the center, they've seen the physician, and it's been billed. And we use billing data to identify these individuals. The second component, which I won't be speaking to today because we're not ready to, is this national access to care survey that's been done. And so we use the Parkinson'S Canada, we use their email list, and we've sent a link to a survey to the Parkinson'S population across the country, and they've filled the survey out. And this has been done also internationally. So the survey was just completed in Portugal. It's been completed in Germany. It's being done in France as we speak. Greece and Spain are looking at doing it as well. So we're going to have a very interesting body of international data to compare. So, but backing up to the first component of this work, so this geographical analysis, the objectives of this are to identify spatial patterns of Parkinson's disease and Parkinsonism prevalence, but also health service use by different provider types. And so we're interested in all providers, but also neurologists and family physicians and so forth. And this is done at an ecological level. So what I mean by that is that it's not looking at the individual, but it's rather aggregate into populations. So comparing groups over space. So ecological level data. And then the second is to explain individual and contextual level factors that are associated with utilization of service. And so individual, so age, gender, comorbidities, et cetera, but contextual factors, including things like you know, area level income would be one example of a contextual level factor. So not individual income, but rather the you know, education context within which somebody lives. And this analysis is done at the individual level in the sense that we are looking at these factors as they relate to specific individuals' utilization of care. So that's ecological versus individual. So there's two sort of levels being looked at. So back to this conceptual framework. So as I pointed out, you can't look at all of these things in any one study. There's just too much here. And so the sort of the access measure that we're looking at is realized access, and this is actually going to and receiving care. So so that's that. And then factors we're looking at include geographic location, but also a range of these other individual level characteristics, including you know, health beliefs, gender, culture, transportation, etc. A lot of these were covered in the survey. For this analysis, we're limited a little bit more to things like income and individual characteristics. So not quite as broad as this circle suggests. So the study area is Ontario. So this is a province, the most populous province is in Canada, 14 million people, huge province, geographically and demographically very, very diverse in terms of range of care across the province. As you might imagine, you know, places like Toronto and Ottawa have excellent world-class care with large numbers of physicians and neurologists and so forth. Whereas if you go up to someplace like, you know, Kenora or Cochrane, it's quite a different world in terms of you know, care access. The geographic unit of analysis are LINs, so local health integration network sub-regions, of which there are 76. This is sort of an administrative area that's was developed by the Ministry of Health of Ontario. And each of these has about 140,000 people and on average, or median, and one acute care hospital at least. So I won't get into this in detail, but this was a population-based study, and what that means is simply that every single person is considered within this. It's not a sample, so basically anybody who met certain criteria specific to their health or access to care were included, right? So it's a population-based study, and it's retrospective, meaning that we're looking back. So we're looking at past utilization, not current or future. So it's using administrative health data. And so the Institute for Clinical Evaluative Sciences, where I'm a scientist, they have huge databases that include all of the Ontario health insurance data, national ambulatory data, all of the hospitalization data. Plus they've got boatloads of information on specific physicians, their locations and specialties and so forth, and then census data as well. And so using that, we're able to do this kind of work. In terms of identifying cases of Parkinson's, we used what's known as a validated algorithm. And so ultimately, there are disease classification codes that you could point out that are very specific to Parkinson's, and then you develop an algorithm or a series of algorithms to sort of test which would be most effective at identifying true cases of Parkinson. And so how they test this is simply to create these various algorithms and then pull these cases, and then using charts, so the actual physical charts of these individuals. You pull a sample from the algorithm, the population that you've got, pull a sample and then go to the charts to actually verify to see whether these individuals are in fact true cases of Parkinson. And so the algorithm that was used was found to be quite highly sensitive and highly specific, so quite reliable, I think, for this kind of analysis. This, as I said, was a retrospective study, and it goes back to the years 2013 to 2018. So we looked at every single health service use in the population over this 5-year period. So, ultimately this algorithm pulled out 103,000 patients in Ontario, going back to 1992. So basically anybody who was potentially diagnosed from 1992 on. And so we had this 103,000 people, and then we excluded ultimately 67,000 of them for a range of reasons, including missing information on sex or no locational information, but the vast majority were cut because they had died between 1992 and the study period. And so we ended up with 35,482 patients in this cohort. So the analysis itself, the two objectives, the first was to identify spatial patterns of Parkinson disease and Parkinsonism. So we used age standardized rates to calculate incidence and prevalence and service use. The population was 60 years of age and over. Again, we analyzed this at the LIN level, so local health integration networks of 76 of them. We calculated and mapped rates of the disease, and also we calculated comparative morbidity figures for each outcome, and I'll explain that in a moment. We did some basic analysis to see if there's autocorrelation within the data, and so we found used Moran's I and Lisa statistic, and this was done using R and ArcGIS. So just some of the descriptive spatial analysis showed here that there are quite, well, the first map is rates. That's this one right here. So this is age, sex adjusted rates per 1,000 people. And the second one is these CMFs, or the comparative morbidity figures. So in terms of rates, we see clearly that the more northern areas of the province have considerably lower rates than the urban areas, so around Toronto and the Ottawa area and parts of southern Ontario. These gray areas are actually not reportable for the moment. They're either due to small counts, so we can't report them, so for privacy reasons, or they're indigenous, largely indigenous communities, and that reserve the right to review the data before it's released. And this is an arrangement that ICES has with these indigenous communities. So until they give approval, we won't release the data. And so, fairly clear sort of spatial, sort of urban-rural distinction, I think, in terms of these rates. The comparative morbidity figures is sort of a bit more meaningful way to look at this data. And a comparative morbidity figure, or CMF, is a ratio of standardized local rates to the expected global rate. So in other words, what we see here is that, so if you have a CMF of greater than 1.2, these red areas, or darker red areas, are 1.2 times higher than the average for the province. And so again, this clearly sort of illustrates, I think, the rates are considerably higher. CMFs are quite high, so 1.2 times higher than the average in the Ottawa area and big parts of the GTA and so this Golden Horseshoe area, London, and rates are also quite high in the Windsor area. In terms of health services use, so this is realized access. Here we have, again, two maps. This is showing the GP and FP visits. So that's general practitioner and family physician, so GP, FP. And then the second map is neurologists. So both maps show the CMFs again. And results sort of indicate that in terms of for the GPs and FPs, there's statistically significantly high CMFs in rural and northern areas. Windsor is significantly low, which is kind of interesting. Not entirely clear what's going on here, but it's because if we look at the neurology map, neurologist visit maps, it's also low. So clearly, in the previous, we saw that the rates of Parkinson's are quite high there, and yet utilization of care is very low. For neurologists, we see the opposite pattern for compared to the GP and FPs. Here, service use is high and quite low in the cities, and rural northern areas show very low service use. So I haven't showed the hospitalization rates or the CMF maps, partly because the data wasn't quite as good, but what you typically see with hospitalizations is that there's a very high use of hospitalizations in rural and northern areas versus urban areas, because if you have low access to care, sort of at a more regular level, you end up delaying care and wait until things get serious, and then you get hospitalized ultimately. So if access to care is poor, hospitalization rates tend to go up. So I'll get back to a few of the sort of main findings from that in a moment, but I just want to move on to the second objective, which is to examine individual and contextual factors associated with service utilization. So here we used multivariate regression. It was negative binomial modeling at the individual level. So the dependent variables were service utilization, which were counts, by specialty type. So we looked at all specialties combined, GPs and FPs, neurologists, and hospitalizations. And then the independent variables that were used included spatial accessibility. This is an index that I'll talk about on the next slide. The Ontario Marginalization Index, which is broken into several components, including residential instability, material deprivation, and ethnic concentration. We looked at comorbidities. So more comorbidities, this is an index that is utilized. So comorbidities are other related or unrelated health problems that might exist. Rural residents, and then age, sex, dementia, and Parkinson's longevity. So how long someone has lived with Parkinson's. So this is, I will not go into too much detail here because it's a lot to explain, but I think it's kind of, this is one of the really unique aspects of this research, I think, is the way we've looked at spatial accessibility. So I showed you the slide previously of distance decay. That's commonly used. Another common approach to looking at sort of geographical access to care is using a physician population ratio, whereby you just sort of count the number of people in the area and the number of physicians, and get a ratio, right? Both of these have problems. In the case of the physician population ratio, it has a few issues in that it fails to include movement of people across boundaries. So you might live in a designated area, you know, at the edge of that area, and you access all of your care right next door, right? So you wouldn't even access the care within your area, and that's a problem. And then also within the boundaries. So if you have a geographical area and you live at one end, and the care provider is at the other end, it doesn't account for that distance in any significant way. So there's distance decay within the boundaries you're looking at. So this assumption that everyone has the same access within a given area is problematic. So what we did is use what's known as a two-step floating catchment area approach. And this sort of builds on this physician population ratio idea, but instead it uses what are known as sort of floating catchment areas, and these overlap. And so the size of the catchment is ultimately determined by us using road network data, and we determine the amount of time that we consider sort of a realistic amount of time that people would access care within that area. And so we use 60 minutes as sort of as what we thought was a meaningful time. And so where, you know, all services within that catchment area are considered accessible if they're within 60 minutes, and all locations outside are not accessible. So that was the approach we used, but problematically, this method does not differentiate accessibility within that 60-minute range, right? So of course, you know, 60 minutes is the maximum, but if you're, you know, 20 minutes away from your service provider within that catchment, you're going to have different access. And so we used what's known as a sigmoid distance decay function to account for decreasing access as travel time increased within a given catchment area. And so this is ultimately known as sort of a sigmoid 2SFCA function. And that was too much detail, and I apologize, but I thought I wanted to try to explain it a bit because it is actually quite novel, and I have to say I have to give a lot of credit to Mike Sawada for helping out with this, because this was fairly complex and quite unique. And so just some of the key results, I'm just going to speak to the red boxes here. So we saw, you know, the measure of spatial access is on the left here, and then we ran models for all specialties, neurologists, and GP FPs. So sorry, on the left are all of the significant variables that we looked at, and then on the top row are all the types of care specific. And so in terms of spatial access, we can see that you know, 1 is the lowest level of accessibility and 5 is the highest level of accessibility. So 1 is the reference category. And so as accessibility increases, while it's not a linear relationship, there's clearly the higher levels of accessibility demonstrate a higher likelihood of accessing care. These are all significant. In terms of material deprivation, we see a similar pattern where 1 is the lowest level of deprivation, and that's the reference category, and 5 is the highest. And as this is a very clear trend, as deprivation increases, access to care decreases. And so this is perhaps, again, not surprising. Costs are associated with accessing care, whether it's direct or indirect. And so we see that quite clearly here in the context of Parkinson's. For general practitioner visits, ethnic concentration seems to matter. And so the lowest level of ethnic concentration, the lowest concentration of ethnic groups is the 1, and that is the reference category. And as ethnic concentration increases, we see a decrease in access and care. And then other factors include things like age. So as age increases, the care goes down. As females are less likely to receive care. Being in a rural area, less likely to receive care. If you have dementia, you're more likely, and if you have lived with Parkinson's for a longer time, you're more likely to receive care as well. So I will summarize these. There's a lot of detail. And so just so spatial accessibility having dementia, and the longer you live with Parkinson's disease, these are all positively associated with different types of care, and in most cases all types, but in the case of longevity, just neurologists. So so it's clear, in terms of spatial accessibility, the closer you live or the better accessible that care is, the more likely you are to use it. So that's fairly to be expected, I would think. For factors that were negatively associated with care, we see that material deprivation was an important one. Having more comorbid conditions, being older, being a woman, and increased ethnic concentration were important factors that negatively were associated with accessing care. Also, living in rural areas was associated with negatively with all types of care, so neurology visits, and living in a rural area was negatively associated with neurology visits, but positively associated with GP and FP visits. So there's a bit of a consistency there, certainly with the maps that I showed you earlier. Access to care looked like certainly the providers were all located in urban areas if you're neurologists. And the family physicians tended to serve the rural population more for Parkinson's. So just to summarize, so there's clearly marked spatial variability in prevalence and service use. So higher prevalence of Parkinson's disease in urban versus rural areas. And this is interestingly inconsistent with some of the previous studies. So a study in Alberta found the opposite, that there were higher rates of Parkinson's disease in rural areas. A little less consistent, there's a study in Manitoba that showed that rates were lower for some socioeconomic groups in rural versus urban areas. So it seems to be playing out depending on socioeconomic status a little bit in Manitoba. So we need to look at this in a bit more detail, I think, to understand what's going on. There seems to be greater reliance on family physicians in rural and northern areas. That's not a huge surprise, as neurologists tend to be associated closely with teaching institutions and hospitals, and they, to support a neurologist, you need a larger population, and so they're urban focused. Interestingly, in Windsor, this is an area of very low level of access, but high rates of Parkinson's. And then in areas like Thunder Bay, which is quite rural, they actually had quite high levels of access overall, which is surprising as well. So factors associated with lower access to care included marginalization, age, comorbidity, and being female. And these findings are fairly consistent with previous studies that aren't related to Parkinson's disease. And so these are things, marginalization is commonly found in access to care research generally. And so this is, what we found here is not perhaps Parkinson's specific. It's an access to care issue more generally. So, I think these findings demonstrate that there's a need for improved access in rural and northern areas for the most part. And I think it's interesting to see COVID has had a few, negative aspects, but I think there are perhaps some good things that are going to come out of it, and that is greatly improved e-health. So we're seeing access to physicians, no matter where you live, improve quite dramatically. In that, you can be in Northern Ontario and access your family physician in Toronto or a specialist in Toronto much better now than you did perhaps a year and a half ago. So that's maybe one plus associated with the COVID pandemic. And there's also, what we found, I guess, is that there is I guess a real need to improve Parkinson's care models that sort of address some of these, specific population issues. So you shouldn't be denied access for whatever reason, if you're, lower income or living in an ethnically diverse neighborhood, clearly the system's not intending to deny care, but the realities are if people are not accessing care in these neighborhoods in the same way as in other neighborhoods, this is a problem and this needs to be addressed. So we need to be focusing attention on increasing access in some of these specific underserviced populations. And I guess another sort of key outcome of this research is that sort of from a bit more methodological perspective, and that's the utilization and testing of this 2SFCA method that we used, and it's I think quite interesting, and we look forward to using it in other contexts as well. In terms of next steps for this kind of work, currently, as I think I mentioned, we're doing this national and international survey among people with Parkinson's, and so data collection is complete in Canada, but ongoing elsewhere. I think some of the things we found here are quite high level in the sense that yes, we found patterns of differential use and so forth, but explaining these becomes quite challenging. And I think what's required is a qualitative study that would perhaps sort of get at the core issues and discuss some of these issues in depth with Parkinson's patients. And I think also we need to perhaps do greater analysis to look at some of the factors that are affecting prevalence across the province. This is not well understood. There's research looking at exposure to various chemicals, for example, that are associated with Parkinson's or higher Parkinson's rates and seen as risk factors. And farm workers, for example, are exposed to many of these chemicals that we're concerned about. And so it might be interesting to sort of focus some of the analysis on specific populations to try to understand what's going on in that regard. Phew, that was way over time. Spoke too quickly. I apologize. But with that, I would like to thank you for your interest. And certainly I'm open to any questions that you might have, whether they're more general or more technical. I'm happy to help. And I would ask Mike Sawada to perhaps be ready for a technical question if there's any.
That's awesome. Thank you. I do have a question, actually. I can start off these questions. So your Windsor being lower access to healthcare, but higher number of people that need the healthcare.
So prevalence is high, access is low, yeah.
Okay, so is it possible that they're going over the border to get this access?
It's possible. So this is always an issue when you're dealing with any sort of geographical unit, right? Is that you can't tell what might be going on as people leave, right? So you could say the same thing about people who live on the border of Manitoba and Ontario or Quebec and Ontario, is that people might be seeking care elsewhere. In the context of other provinces, this data is accounted for, but in the context of going to the United States, it's not. So yes, that is a possibility. And I think we would want to try to get at that if we perhaps did, for example, qualitative interviews. It would be interesting to talk to people in Windsor and perhaps key informants, so physicians in Windsor, to see, what's going on here. Are people seeking care, not receiving it in Canada and seeking it elsewhere as a result? So yeah, great question.
Well, thank you. Great presentation.
Thank you.
Sarah, you had a hand up.
Yeah. Hey, Eric.
Hi, Sarah.
How's it going? I had a couple of questions. One was, have you considered looking at GP level variables? So I was thinking about, if your GP retires, how easy is that process of switching to another GP, and that's going to affect someone's ability to have access to care?
Yeah, well, certainly, well, that would have a big effect, I would imagine, if someone's got a GP and then suddenly they don't, clearly. I guess we can make some assumptions that people aren't, GPs aren't retiring differentially across the province. So we could assume that, the age is fairly standard. I don't think that's not true necessarily, but yeah, losing a GP in a community is going to have a big impact over time. We've looked at 5-year age or a 5-year range. And so, I would think that it's fairly stable. You're not seeing any big fluctuations with any of the geographic regions we looked at within that period, but it's hard to know. Yeah, it's a good question. I can't speak to it. I don't honestly know how you would do it, how you would look at that. But
didn't know if you have access to people's records and you could see whether they're
the same physician or not.
Yeah.
Yeah, conceivable.
The thing I wasn't sure, because you see this gendered reaction or gender difference, is Parkinson's research similar to heart disease in that it's very gendered and there's more research on men, and so maybe there isn't this picking up of symptoms for women, or there's a difference in symptoms?
Yeah, that's interesting. So this is a question I always have: is is what we're seeing a question of diagnosis, or is it a question of actual morbidity? Right. So I've been assured by experts in Parkinson's disease that although it's possible that some people might have a delayed diagnosis by a year or something, if you have Parkinson's, you will get diagnosed with Parkinson's. You don't live with Parkinson's for very long before you realize there's something wrong and you seek a diagnosis, right? So, unlike say something like asthma, which is something I've worked on a fair bit, asthma is frequently not diagnosed in a lot of populations. So Indigenous communities, for example, asthma will go undiagnosed for ages. Parkinson's, on the other hand, is diagnosed fairly readily and fairly immediately. So, in terms of gender differences, I would imagine that women are getting diagnosed as quickly as men, but there seems to be a sex difference in terms of both rates and in terms of access to care, and there tends to be socioeconomic factors associated with that, perhaps. At that age, men are increasingly likely to seek care. Women generally in life seek care more regularly than men, but I think as populations age, men tend to a little bit more than women. So, good question.
And I think Karina, you have your hand up.
Hi, thank you. So what is the main approach you think should be taken to increase access, especially in rural areas? Should it be more aimed at education, social justice, better funding, telemedicine? What do you think would be your approach?
Well, I think, this is always a challenge in a province like Ontario, where it's so geographically diverse and distances are incredibly huge, that there's just no way you can have healthcare equality. The access is always going to be unequal, right? And so if you live in, Kenora, in rural Kenora, that you will not have the same access as if you live in, physical access as if you live in Toronto, right? And so, there's no way you're going to, be able to get neurologists to live in northern Kenora to serve that population. And so, the alternatives need to be found, and traditionally, people have had to go to their physician to seek care. But I think, e-health is absolutely the way to go when it comes to trying to provide access to rural and northern communities. It will improve the situation dramatically. And of course, that doesn't mean that they will have as good care necessarily, and an in-person visit can be much better and so forth, but it'll be a big improvement, I think, particularly for access to specialists like a neurologist. Yeah, great question. It's a challenge, and I think governments across Canada have been trying to work on this one for years and try to improve access in northern communities, and it's expensive and challenging.
Nice. So I think Sydney has her hand up. Just one comment. We're at 12:54. So if anybody has to go for anything, please go ahead and take care of whatever you have to tend to. Just making that note. All right, Sydney.
Hi, Eric. Thanks for the presentation. I learned a lot. I was just curious. You were just talking a bit about telehealth and how that's sort of necessary, I guess, to improve the access for certain communities. And I've seen personally, an increase in healthcare, in telehealth, just in our communities with COVID-19. Everything's been moved. I had a prescription eye exam virtually. So I'm just wondering, is COVID-19, is there any research, I guess, sort of if that's affected access to healthcare, and if there are things that have been changed because of COVID that will have longer lasting effects on these communities?
Yeah, so it's interesting. So this survey that I spoke about, we designed it in the midst of the COVID pandemic, and so we actually had a section on how care has changed since COVID, how access has changed since COVID has begun. And I have to say, I'm not going to speak to the results because I don't know them offhand. We're very preliminary results so far, but it's I think what we've I think we can say is that rural residents have seen improved access, and you might say urban residents might have slightly decreased access, in not so much in actually getting an appointment in urban areas isn't the problem so much, but perhaps the quality of care might have fallen off a bit, right? So that's sort of, I guess, one aspect of access. Yeah, I would imagine that your experience with having a virtual eye exam isn't quite the same as the in-person one. Maybe I'm wrong, I don't know.
I should clarify, I went in person, but the doctor wasn't there. So I still had my eyes checked, just the doctor was virtual.
Interesting, okay. Yeah, so, but I think what's interesting is that new strategies are being found. And I think, you look at access to care for family physicians and, the types of things that people go to physicians for, it's 9 out of 10 times it's for, a sore throat or something very minor that really doesn't require that much, one-on-one physical interaction. Like, things can be done remotely. So, the risk, of course, is that will rely too heavily on telehealth or e-health. But I think integrating e-health into the healthcare model a bit more would be a good thing, and it would certainly improve access within northern communities. That's for certain. I'm not sure. Did I answer your question?
Yeah, you did. I would just be interested to keep my eye on that as we move out of COVID, since I mean, a lot of the things that weren't used but were available, but now they're being used. So it seems like it'd be a step backwards to then stop using some of these.
Yeah. No, well, it's definitely going to be an area of research that you're going to see a lot of publications coming out in the next few years, looking at how access to care has changed as a result of, sort of as a result, I guess, of COVID, but more specifically the introduction or increased use of e-health or telehealth.
Yeah. All right. Thanks, Eric.
Yep.